So this is the activity for Chapter 22, the lymphatic system and immunity. So we're going to start with part 1, not another cold. So imagine that you are sitting in your A&P class one day when the person next to you sneezes without covering their mouth. The water droplets from the sneeze contain a rhinovirus, a virus responsible for the common cold. You inhale the rhinovirus and it manages to escape your respiratory defense systems and invades the mucosa membrane of your nose. Once inside the epithelial cells of the mucosa membrane, the rhinovirus takes over the cell's machinery to cause it to produce more rhinovirus particles. As the virus particles multiply and spread, you have cells in the upper respiratory tract that are infected with the viral particles, and you also have free viral particles in the interstitial tissues in the upper respiratory tract. So let's follow the coordinated immune response to this common cold. So a picture is worth 1,000 words. So here is a picture to show you what we're dealing with. We're not going to go into the level of detail in this picture, but what I wanted to show you is that on the left side we have a cell which is infected by the virus. So the virus are these little gray particles. The virus gets inside the cell and then it hijacks the cell's machinery to start making new viral particles. So the cell ends up not doing its normal job and instead is just churning out new viruses. And as the viruses are released, they will move through the fluids in the body where they will encounter and infect other cells. So just a reminder, there are two issues that we are facing with this viral infection. We have infected cells that viruses have taken over and are using to make more viruses. And because they're using all of their machinery to make more viruses, they're not doing their normal function. So we need to get rid of these cells that have been infected. And the second problem is that we have free viruses that are in the body fluids that are searching out new cells to infect. So this is why we have two sides to our adaptive immunity. We have cell-mediated immunity to find and take care of these viral infected cells. And then we also have antibody-mediated immunity, which will help us to clean up the free viruses in the bodily fluids. So number one, what is the first line of cellular defense? What are these cells called, and what will they do to the antigens they digest? So the actual first line of defense will be the physical barriers that prevent pathogens from entering the body in the first place. But the first line of cellular defense, so if they get past the physical barriers, the first cells that will become involved will be the phagocytes. And these are your dendritic cells, your macrophages, and your microphages. Dendritic cells are technically pinocytes, but we're not going into that level of detail. So for simplicity's sake, we're just going to lump them into the phagocyte category for this particular activity. So dendritic cells in the mucosa membrane of the respiratory tract would likely be the first to encounter a free-floating virus. Free macrophages could also detect a virus. Neutrophils, which are a type of microphage, specialize in responding to and phagocytizing bacteria, and eosinophils, which is another type of microphage, specialize in responding to and phagocytizing viruses in addition to parasites, as we talked about in Chapter 19. So after digesting the virus, the phagocyte will attach some of the viral proteins to its MHC class II receptor on its cell surface. So here's an image. So in this image, we're looking at a macrophage, and the macrophage is taking in a pathogen up here through phagocytosis. Then once the pathogen is inside the cell, it is digested with enzymes from the lysosomes, and then bits of that pathogen, which would be called antigens, are then attached to an MHC2 receptor and stuck on the surface of the macrophage. So remember that phagocytes are what we call antigen-presenting cells, and so they have class II MHC receptors. Because all nucleated cells also have class I MHC receptors, this phagocyte will also display viral proteins on its MHC class I receptors, which is not shown in this particular image. The phagocyte will then go to a nearby lymph node where it will present its antigen to T cells. Number 2, what T cell is going to scan the antigen presented by the macrophage? Describe how the T cell becomes activated and then what happens next. So MHC class II receptors are scanned by CD4 T cells. So remember, 2 and 4 go together. So here in this picture, we again have a macrophage, and again we have an antigen that is being taken up through phagocytosis. The antigen is then digested using lysosomes, and then pieces of that pathogen are stuck to class II MHC proteins and stuck on the surface of the cell. And then a CD4 T cell is going to come along and scan the antigen in that MHC class II receptor with its T cell receptor. So when a CD4 T cell that has a T cell receptor that matches the antigen perfectly, we call this antigen recognition. Then the CD4 T cell requires co-stimulation by cytokines that are released from the phagocyte, and with the co-stimulation and the recognition of the antigen, this particular CD4 T cell will become activated. That specific CD4 T cell then divides to produce a bunch of helper T cells that all have the same T cell receptor to recognize that specific antigen. And some memory helper T cells will also be produced. Helper T cells are then going to go on and produce cytokines that will be necessary for the next steps, which is the activation of B cells and the activation of cytotoxic T cells. So keep in mind that helper T cells, which are CD4 T cells, are necessary for both the cell-mediated response and the antibody-mediated response. So they're kind of like the middleman in between the two sides of the adaptive immune response. So number 3, next describe the cell-mediated adaptive immune response. Explain which cells are activated and the result of the action of these cells. So MHC class I receptors are scanned by CD8 T cells. So remember, 1 goes with 8. So both the phagocyte that originally encountered the virus and any normal cells already infected by the virus will display viral proteins or viral antigens on their MHC class I receptors. So now we have a picture of a target infected cell. So now the virus is inside this cell. And so because this is just your normal everyday run-of-the-mill body cell, it is going to have MHC class I receptors, and it's going to have a piece of one of those viruses stuck in this receptor. The MHC class I receptors are scanned by CD8 T cells with their T cell receptor. So when a CD8 T cell that has a T cell receptor that matches the antigen perfectly, we call this antigen recognition. So co-stimulation is also required in this case before the CD8 T cell can become activated. And in this case, there are going to be cytokines released by the cell that has the MHC class I receptor and cytokines that are released by activated helper T cells, which we talked about in question number 2. And so with these cytokines, this CD8 T cell will become activated. So that specific CD8 T cell will then divide to produce a bunch of cytotoxic T cells that all have the same T cell receptor to recognize that specific antigen, and some memory cytotoxic T cells will also be produced. Later, that CD8 T cell will also make regulatory T cells that will help to eventually turn off the immune response. So now for the second part of the question, the result of action of these cells. So activated cytotoxic T cells will now go out into the body and seek out any other cells that are displaying that same viral antigen on their MHC class I receptors and will destroy them. So cytotoxic T cells kill infected cells in 3 ways. First, they can release perforin proteins that punch holes in the cell membrane of the target cell, which disrupts the solute and osmotic balances, and that is shown down here. So when you have an infected cell displaying this particular foreign antigen in its MHC class 1, this is recognized by an activated cytotoxic T cell with its T cell receptor, and it's going to release these perforin molecules, which are going to punch holes in the membrane of the target cell, which will destroy it because it can no longer maintain differences between the inside of the cell and the environment. The cytotoxic T cells can also release enzymes that activate apoptotic or suicide genes inside the target cell. And cytotoxic T cells can also secrete lymphotoxins, which can disrupt the function of the target cell. The end result is that the infected cell gets destroyed. And then after killing an infected cell, the cytotoxic T cell will then go in search of more infected cells to destroy. So number 4, next describe the antibody-mediated adaptive immune response. Explain which cells are activated and the result of the action of these cells. So B cells have antibody-like molecules stuck in their plasma membrane, and these are called the B cell receptors. And here's a picture. So up here in the top right, we have a B cell with a B cell receptor stuck out here. And then when a B cell with a receptor, which again is like an antibody, that matches one of the epitopes on a free-floating viral particle shown by the little yellow dots here, it will then bind to that viral particle. So here we see the B cell receptor is binding to the antigen. And again, the B cell receptors are very specific for a specific type of antigen, just like the T cell receptors. So once bound to an antigen, the B cell will internalize this receptor that looks like an antibody, and it will move the antigen to an MHC class 2 receptor. So remember that B cells are also antigen-presenting cells and have MHC class 2 receptors. A previously activated helper T cell, and we talked in question 2 about how the helper T cells get activated, will recognize the antigen in the MHC class 2 receptor with its T cell receptor, and it will release cytokines that will activate the B cell. The activated B cell then undergoes cell division to make more B cells, as well as making memory B cells. These B cells will then differentiate into what's called plasma cells, which start making millions of antibodies that match that initial B cell receptor that recognized the antigen. The antibodies will then seek out and bind to any free virus particles in the body fluids. Number 5. Draw a diagram showing a summary of the adaptive immune response to the rhinovirus. Add to your diagram some of the innate defenses that will also come into play to help fight the rhinovirus infection. Make sure to label which responses are adaptive or specific and which responses are innate or nonspecific. All right, so this is going to be a pretty big diagram with lots going on, but I've broken it down into steps, and so hopefully you can go back and re-watch this part with the different steps until you kind of get the whole response down. So we're going to start with some infected body cells. So these are cells that have been infected by a virus. And then we also have the free virus, which is virus that is in the bodily fluids that is hunting out new cells to infect. So remember, we kind of have two different problems to deal with: infected cells and free virus particles. So also I have a little key up here in the upper right corner. So the first thing in my key are the MHC class 1 receptors. Remember, these are found on all nucleated cells in the body. So the infected body cells would also have this type of receptor. And when a body cell is infected, eventually pieces of a viral protein or viral antigen will get displayed in the MHC class I receptor. So we're going to start over here with a phagocyte or a dendritic cell. So this is our first line of cellular defense, as we covered earlier. And so a phagocyte or dendritic cell will end up engulfing one of the viral particles that it encounters. It will take that viral particle on the inside, it will break it up into pieces, and then it will display some of the viral antigens onto an MHC class II receptor. So notice the color difference. This is an MHC class II. These more gray looking ones are MHC class Is. So the next stage is that we have a CD4 T cell that is going to come along, and it is going to look at this antigen in the MHC class II receptor with its T cell receptor. So these little Pac-Man shaped things are going to be my T cell receptors. And so if there is a perfect match, if the T cell receptor of this particular CD4 T cell recognizes this antigen, then that is called antigen recognition. Now the CD4 T cell does not become active until it also gets co-stimulation, which is accomplished by cytokines that are released from the phagocyte that is displaying the antigen. So once the CD4 T cell becomes activated, it is going to undergo cell division, and this is that process we call clonal selection, which means only the CD4 T cells that have a matching TCR receptor are going to undergo cell division. And with the clonal selection, it's going to make a bunch of helper T cells as well as memory helper T cells that will enable a faster response the second time we encounter this antigen. So that is my T cell response, which is, as I mentioned before, sort of the middleman of the adaptive immune response. Meanwhile, we have CD8 T cells with their little T cell receptor. The CD8 T cells scan MHC class I. So remember, CD4 scans 2, 8 scans 1. So the CD8 T cell is going to scan the class I receptors. It will either recognize an antigen on an infected cell, or it could also look at the MHC class I receptor that is on a phagocyte, which I didn't include in this drawing because this drawing is already pretty complicated. So I'm just showing the CD8 T cell recognizing an antigen on the MHC class I receptor of one of the infected body cells. So again, we require co-stimulation before the cell can become activated, and in this case there is co-stimulation from the infected body cell as well as, and this is necessary, co-stimulation by activated helper T cells. So once the CD8 T cell becomes activated, it will also undergo clonal selection, which means it will undergo several rounds of cell division. And this will make a lot of cytotoxic T cells, which are the TC cells. It will make memory cytotoxic T cells for a faster response in the future. And it will make those regulatory T cells a little bit later on, which will help to turn off the immune response. So now we'll focus on the cytotoxic T cells that were made. So the cytotoxic T cells have the same T cell receptor as that original CD8 T cell, and that same T cell receptor will recognize the same antigen. So it will find an infected body cell by recognizing the antigen. It will then release perforins, enzymes that cause apoptosis, and lymphotoxins, all of which are designed to kill the infected body cell. And then this cytotoxic T cell will then go on and find any other infected body cells it comes across and kill them as well. So this is my cell-mediated immune response, where now I have these cytotoxic T cells which are going to go out and find and kill any infected body cells. Over here I have a B cell, and B cells have this B cell receptor which looks like an antibody stuck in the membrane, and some of the free viral particles that are floating around in the body fluids are going to be recognized by a particular B cell with a matching receptor. And when we have a viral particle bind to that B cell receptor, that B cell receptor is internalized and that viral particle is transferred to an MHC class II receptor. So again, B cells are antigen presenting cells, so they have MHC class II receptors. And that antigen is then going to be recognized by a helper T cell. So a helper T cell comes along, recognizes that antigen with its T cell receptor, and then the B cell gets co-stimulation by cytokines released by the helper T cell. That is then going to activate the B cell, and once the B cell is activated, it's going to undergo clonal selection, which again, just that type, one single type of B cell with that single type of B cell receptor is going to start dividing, and it's going to produce plasma cells and memory B cells, both of which match that original cell with that original receptor / antibody for that particular antigen. The plasma cells then become antibody making factories. So they then churn out millions of antibodies, which then go out and bind to the free viruses that are in the bodily fluids. And we call this our antibody mediated immune response, and this is aimed at getting rid of the free viral particles in our blood and interstitial fluids. So we're also going to add some innate immune responses to our diagram. So we have infected body cells that recognize that they have been invaded by a virus, so they release chemicals called interferons, and the interferons go to nearby body cells that have not yet been infected and tell them to start making a lot of antiviral proteins to help prevent them from becoming infected. So that is the interferon response. We also have NK cells, which recognize that this infected body cell is not normal. It does so through a different mechanism than using the MHC class I receptors. But once it recognizes that the body cell is not normal, it is going to release perforins that will punch holes in the membrane of the body cell and kill it. So that is the NK cell response or immune surveillance response. The phagocytes and dendritic cells that encounter the pathogen will also release cytokines called pyrogens. Pyrogens will cause the hypothalamus to raise the set point of the body temperature, which results in fever. We also have complement proteins that can become activated, and they can bind to the viral particles, and they can also help with the inflammatory response that we'll see in just a moment. And then we have mast cells and basophils that respond to the infection by releasing histamine and heparin, which are two chemicals that promote inflammation. So we get an inflammatory response both from the secretions of the mast cells and basophils, as well as the complement proteins can also increase inflammation. So then the last part of the question was to label these different parts of the immune response as either adaptive or innate. So the phagocytes or dendritic cells are part of the innate response. Innate is non-specific, meaning a phagocyte or dendritic cell will engulf anything it thinks is foreign. It's not only going to engulf just one specific type of virus, it will engulf any virus it comes across. So that is part of your non-specific defenses. Pyrogens are also part of your innate non-specific defenses. So are the release of interferons. The NK cells is the one type of lymphocyte that is part of your innate or non-specific defenses. They will kill any cell that is abnormal. They are not limited to just finding a cell that matches a specific receptor. They will kill any abnormal cell, so that is part of your innate non-specific defense. The mast cells and basophils and the inflammatory response is also going to be part of the innate nonspecific defenses, as well as the complement proteins. And then we have the adaptive specific defenses, which are going to be your helper T cell and CD4 T cell response, your cytotoxic T cell, regulatory T cell, and CD8 T cell response, and your B cell and plasma cell and antibody production response, those are the three prongs of your adaptive immune response. So this is a response to a cold virus summarized in a single diagram. Number 6, looking at your diagram for number 5, discuss the timeline for these various events. Which events happen first? Which events happen later? So the innate defenses are going to be the first to respond to an infection. The phagocytes and dendritic cells will engulf pathogens and present antigens at lymph nodes, which will be the start of the adaptive immune response. But then the adaptive immune response also requires multiple rounds of cell division. So in the meantime, we continue with our innate defenses. We also have phagocytes and infected cells releasing interferons, which will increase the antiviral defenses of nearby cells. The NK cells, which is part of our immune surveillance, will attack and destroy any abnormal cell they encounter, including viral infected cells, so they can help to start getting rid of the viral infected cells while we're waiting on our cytotoxic T cells to become available. Complement proteins in the plasma will become activated when exposed to viruses and viral infected cells. Mast cells and basophils will release histamine, heparin, and other chemicals that promote inflammation. And the phagocytes will release pyrogens that cause the hypothalamus to raise the body temperature, which is called a fever. And so again, think of the innate defenses as trying to slow down or stop the infection of the pathogen, while the adaptive responses are coming online and gearing up to take out all of the infected cells and all of the viral particles. So because both the adaptive defenses, which are the cell-mediated immunity and the antibody-mediated immunity, both of these adaptive defenses require antigen presentation, antigen recognition, then activation, and then cell division, which is that clonal selection we talked about. All of that has to occur before the response ramps up. So the adaptive defenses are going to kick in after the innate responses have already acted to contain the infection. So the cytotoxic T cells, which are your cell-mediated immunity, are going to be the fastest of the adaptive defenses. The plasma cell production of antibodies, which is your antibody-mediated immunity, will take the longest, and antibody levels do not become elevated until 2 to 3 weeks after the initial infection. So again, the innate nonspecific defenses attempt to halt or slow the progress of the infection until the adaptive or specific defenses can come in and clean everything up and eradicate all traces of the pathogen. So here is a graph from your textbook, and this graph was specifically geared toward bacterial infections, but it's going to look very similar with viral infections as well, except you may see more eosinophils than neutrophils. But in any case, the point of this graph is to show you that the innate responses are going to be the first to respond in your first week of infection. The cytotoxic T cells will be the first of the adaptive defenses to respond, with antibody levels coming in last at around 2 to 3 weeks after infection. Number 7, what aspects of the immune response are responsible for the symptoms you suffer during the common cold? So things like sore throat, runny nose, nasal congestion, sneezing and coughing, and sometimes a mild fever. So the innate nonspecific defenses are actually responsible for most of the symptoms we experience when we are sick. The cytokines released by the phagocytes, mast cells, and basophils cause an inflammatory reaction in the respiratory tract. So we're focusing on the common cold, so this is going to be in your respiratory system. The activation of nociceptors by the inflammatory response will be responsible for things like a sore throat. Inflammation also causes more fluid to build up in an infected area, which causes swelling, and this is responsible for your nasal congestion, so while your nose closes up and it feels like you can't breathe. In respiratory tract infections, mucus production is also increased to try to wash away pathogens, which can result in a runny nose, which is also helped by the increased fluid to the area by the inflammatory response. Sneezing and coughing are due to the irritation of the respiratory mucosa due to the excess mucus production and the inflammatory response. And then pyrogens released by the phagocytes and sometimes the pathogens themselves cause the hypothalamus to raise the set point for body temperature, which results in a fever. So bottom line, the reason you feel sick is actually because of the actions of your immune response. And this is important. This is why you feel sick after you get a vaccine. A lot of people mistakenly think the vaccine gave them the actual virus or cold or bacteria or whatever they're being vaccinated against. Like you hear people say, I got the flu vaccine and then I got the flu. No, you didn't get the flu. You got the flu vaccine, which caused an immune response, which is the whole reason we take vaccines. And so, yes, after getting a vaccine, you may not feel good for 2 to 3 days, and that is because of your immune response. And your innate immune response is causing all of these symptoms, but it's a sign that the vaccine is working and you are making the necessary immune cells so that you won't actually get infected with the real virus, which could do a whole lot worse damage. So it is the innate immune response that causes these symptoms that is a signal that things like a vaccine is actually working. And yes, you can even run a fever after a vaccine. Number 8, classify the type of immunity we just described: active versus passive, natural versus artificial. Give an example of the other types of immunity. So a person catching a rhinovirus or a cold virus and mounting an immune response is an example of naturally acquired active immunity. It's active because an exposure to antigens is causing the body to make its own antibodies. So active is when the body makes its own antibodies through that whole process we looked at in number 5. It's naturally acquired because you caught the cold by exposure to an antigen in your environment. And in this case, it was the person next to you in your A&P class who was sick. So the other types of immunity are artificially acquired active immunity. And artificially acquired, a person is injected. So a person in this case is injected with an antigen for the purpose of having their body make antibodies ahead of time and getting memory cells. And so again, because you are making the antibodies, that makes it active. Artificial is because you're going to a clinic or a doctor's office and getting an injection. And this is what we call vaccines and immunizations. And so yes, you are going to be going through that whole process we looked at in number 5 in response to the antigens they inject in your body. So yes, you are going to feel sick or under the weather for 24 to 48 hours after getting a vaccine. That is perfectly normal, and it means the vaccine is doing its job. Naturally acquired passive immunity is when a baby gets antibodies from their mother. So the passive part means they are not making their own antibodies, they're being given antibodies. And the natural part is because this is a normal part of what mothers do for their children. Artificially acquired passive immunity would be a person injected directly with antibodies. Again, it's passive because you're being given the antibodies. It's artificial because it's an injection. And this is usually done in the case of a rabies exposure. They don't want to wait the 2 to 3 weeks for your body to make its own antibodies. You need those antibodies ASAP before the rabies can get in your brain and do some real damage. So they will give you the antibodies directly. Number 9. If this rhinovirus infected someone with AIDS, how would this change the immune response you diagrammed in number 5? So a person with AIDS is infected with HIV, which is human immunodeficiency virus. HIV is a virus that attacks and neutralizes CD4 T cells. So if we look back at the diagram we made in number 5, and I'm going to put that up on the next slide, we can see that the activation of the CD4 T cells into helper T cells is a key requirement for both the cell-mediated immune response and the antibody-mediated immune response. Therefore, someone infected with HIV will have reduced helper T cell function, and as a result would also have both a reduced cytotoxic T cell response and a reduced B cell response, so fewer antibodies produced as well. A person with full-blown AIDS is essentially depending totally on their innate non-specific defenses because the adaptive defenses are crippled by the removal of the central players. So if we look at our diagram that we did in question number 5 that showed the entire response, with AIDS, we are taking out the CD4 T cells and the helper T cells, right? So HIV targets these cells and renders them useless. And so without the CD4 T cells and helper T cells, we do not get co-stimulation that is necessary to activate our CD8 cytotoxic T cells, so we lose our cytotoxic adaptive defense. We also do not get the co-stimulation necessary to activate B cells and get plasma cells and antibodies, so we also lose the antibody-mediated defense. So HIV takes out the all-important middle guy that knocks out both sides of your adaptive immune response. All right, so this is part 2, inherited immunological disorder. Billy DeWitt was a normal full-term baby at birth. Beginning at about 10 months of age, Billy suffered from a series of infectious processes such as sinusitis, otitis media, and pneumonia. All of these conditions were successfully treated with antibiotics, but within a few weeks of the resolution of one infection, another would occur. Now, at about 4 years of age, Billy is examined by a pediatrician who notes that Billy lacks palatine tonsils, although he does not have a history of tonsillectomy. Questioning of Billy's mother reveals that she had 2 male relatives who died in infancy from infectious disease. The physician orders laboratory tests that reveal that the quantity of immunoglobulin in Billy's serum is about 1/5 of normal, and that there is a marked deficiency in the number of circulating B lymphocytes in Billy's blood. Tests to determine the functional state of Billy's T lymphocytes are all normal. Billy is diagnosed with a genetic disorder called X-linked agammaglobulinemia, or XLA. He begins a monthly intravenous injection of gamma globulin, which he will need to continue for the rest of his life. Billy should no longer suffer recurrent infections and should develop physically and mentally as a normal child. Aside from receiving monthly injections of gamma globulin, he should lead a normal life now that this course of treatment is in place. So number 1, Billy has a marked lack of B cells but normal T cells. Compare and contrast the production of these 2 types of cells. What else happens to the T cells in the thymus? So all lymphocytes begin production in the red bone marrow, also called myeloid tissue, and all lymphocytes are going to start with cells called hemocytoblasts, just like all of the other blood cells. So hemocytoblasts in the red bone marrow will become lymphoid stem cells, or some of them will become lymphoid stem cells, and then the lymphoid stem cells go on to develop into lymphocytes, which include the T cells, B cells, and NK cells. So the immature B cell lymphocytes and the NK cells will stay and mature in the red bone marrow. Some of the lymphoid stem cells will migrate out of the red bone marrow into the thymus, where they will complete their maturation into mature T cell lymphocytes. After maturation, both the T cell lymphocytes and B cell lymphocytes will enter the bloodstream and migrate to peripheral tissues, lymph nodes, the spleen, and other lymphoid tissues. The second part of the question said, what else happens to the T cells in the thymus? While in the thymus, any T cells that recognize self-antigens are destroyed to prevent autoimmune attacks. So in patients with XLA, the process of lymphocyte formation is disrupted by a genetic mutation so that few, if any, B cells are formed. T cell and NK cell production are not affected. Number 2. What part of Billy's adaptive immune response is disrupted by this disorder? How can we classify the adaptive immunity provided by the monthly injection of immunoglobulins? So since Billy's body cannot make B-cell lymphocytes, he will also not be able to make antibodies. And again, keep in mind that immunoglobulin is another term for an antibody. So they can be called antibodies or immunoglobulins. Since Billy cannot make B cells and thus has no ability to make immunoglobulins, Billy's antibody-mediated immune response is impaired. And the antibody-mediated immune response is also called the humoral-mediated immune response. So because he can't make his own antibodies, he has to be injected with antibodies or immunoglobulins. And so since he is getting a monthly injection of these antibodies, this would be classified as artificially acquired passive immunity. So it's passive because he's not making his own antibodies, but rather being given antibodies directly. And it's artificially acquired because he is being administered the antibodies through an injection in a clinical setting. Number 3, Billy was free of infections for the first few months of life. Why? How can we classify this type of adaptive immunity? So during the first few months of life, a baby is protected by his or her mother's antibodies. So during pregnancy, IgG antibodies can directly cross the placenta and enter the baby's bloodstream directly. After birth, the level of the maternal IgG antibodies in the baby's blood will rapidly decline over the first 2 months. If a baby is breastfed, they will also receive IgA antibodies from the mother's milk. But since IgA antibodies are not as effective as IgG antibodies, babies will typically start having to fight infections on their own at around 2 months of age. So in his first few months of life, Billy was protected by his mother's IgG antibodies, but then he lost that protection, and that is when he started becoming sick all the time. Since Billy was initially getting antibodies or immunoglobulins from his mother, this would be classified as naturally acquired passive immunity. It's passive because, again, he's not making his own antibodies, but rather being given antibodies directly. And in this case, it's naturally acquired because it is part of the normal immune protection that a mother provides for her child. Number 4, what are tonsils? Why might they be small and easily overlooked in Billy's case? So tonsils are a type of mucosa-associated lymphoid tissue, also called MALT, found within the walls of the pharynx. So your textbook goes into 5 of the different types of tonsils. So there is one large tonsil behind the nasal cavity called the adenoid. There are also 2 tonsils at the back of the throat called the palatine tonsils, and 1 big tonsil at the base of the tongue, or actually 2 small tonsils at the base of the tongue called the lingual tonsils. Your textbook does not talk about the tubal tonsils, but those are another type of tonsil, but I won't test you over those since they are not in your textbook. Tonsils actually contain a higher percentage of B cells than any other type of lymphocyte. And since Billy can't make B cell lymphocytes because of his mutation, his tonsils were likely very small and difficult to see. So when you look in a person's throat, like they do at the doctor when they tell you to open up your mouth and say, ah, typically you can see a person's 2 palatine tonsils in the back of their throat. But if these palatine tonsils are very, very small, it can actually look like the patient doesn't have any palatine tonsils, or the doctor can erroneously think that they've had a tonsillectomy when in fact their tonsils are just really, really small. I actually get asked all the time if I've ever had a tonsillectomy, because apparently I have very small palatine tonsils too, but I don't have XLA, so I don't know why. Number 5, review the 7 ways that antibodies are helpful in fighting pathogens. The first is neutralization. Antibodies can bind to sites on viruses and bacteria and prevent them from attaching or entering host cells or from releasing dangerous toxins. Next is precipitation or agglutination. Antibodies can form complex immune complexes when multiple antibodies attach to antigens, and then these complexes can precipitate or agglutinate, which is called clumping. And again, once the pathogen has been precipitated or agglutinated, it can no longer cause problems. You also have activation of the complement system. So antibodies bound to an antigen have active sites exposed where complement proteins can bind and become activated. You get the attraction of phagocytes. So eosinophils, neutrophils, and macrophages will all attack any antigen that is covered in antibodies. Furthermore, you get the process of opsonization, which is when the antibodies attached to the antigens also give the phagocytes something to grab a hold of, which helps them to more easily engulf and destroy the pathogen. You also get an inflammatory response. So antibodies can stimulate mast cells and basophils to release pro-inflammatory molecules like heparin and histamine. And you get prevention of pathogen adhesion. So the antibodies in bodily secretions, which are your IgA antibodies, and your secretions are things like saliva, mucus, perspiration, the mother's milk that we talked about. These can make it difficult for pathogens to attach to and penetrate epithelial linings so that they have a harder time entering the body to start with. And in this last section, part 3, we're going to look at lymphedema. So a 55-year-old male was diagnosed with squamous cell carcinoma on the left side of his face. He underwent a surgery to remove the cancer, and during a left neck dissection, 4 lymph nodes in the neck were also removed to test for the presence of cancerous cells. He subsequently developed lymphedema extending from his forehead to his lower neck. And so this would look like something like this, where you would have a lot of swelling on the left side of the face. And so you can especially see it down here in the chin area. You can see the extra fluid in the tissues. So number 1, what is lymphedema and what causes it? Why do you think this patient developed lymphedema? So lymphedema is a swelling of tissues due to a buildup of interstitial fluid that results from a blockage of the lymphatic vessels that would normally drain the excess fluid. So if you remember from chapter 21, more fluid is filtered out of the blood capillaries than is reabsorbed, and the extra fluid is returned to the venous system by way of the lymphatic system. So it is picked up by lymph capillaries. It travels through lymphatic vessels that have valves in them. It'll pass through lymph nodes. It will eventually make its way to a lymphatic trunk, then to a lymphatic duct, and then back into the venous system. So in this patient, 4 lymph nodes were removed in the neck. Removal of lymph nodes often severs the lymphatic vessels serving a particular area and prevents normal drainage of lymph from that area. So this patient likely developed lymphedema because of the removal of the lymph nodes. Lymphedema can be treated by massaging the tissues to encourage the movement of the lymph to other areas that still have an intact lymphatic pathway. And you can also elevate the area or change the sleeping position to help the fluid drain into another area that still has intact and functional lymphatic vessels. Number 2, why did the doctors want to check the lymph nodes for cancerous cells? So cancer cells that can metastasize have gained the ability to break loose from their original tissue of organ and move to other areas of the body. Loose tumor cells can more easily enter lymphatic vessels versus blood vessels because remember, lymphatic vessels have a structure that allows the relatively easy entry and exit of immune cells because B cells and T cells are constantly going in and out of the lymphatic system. With blood vessels, only sinusoidal capillaries have holes large enough to allow cells to move in and out, and sinusoidal capillaries are only found in places like the spleen and the liver. So if we look at this diagram over here, so we have a tumor up here. So the lymphatic vessels are going to be easier for the tumor cells to enter. And so the tumor cells will then travel to nearby lymph nodes. So the presence of cancer cells in a lymph node is a good indication that a cancer has metastasized, and it can help the doctors plan the next course of treatment. And cancer cells will end up in nearby lymph nodes first, and so these are the ones the doctors will look at initially. So you are more likely to have cancer cells in a proximal lymph node than in a distal lymph node. Again, just because of the flow of lymph, so the cells are going to end up being lodged into closer lymph nodes first. Number 3, describe the flow of lymph in this man's body, beginning with the left side of his face. Indicate where his drainage problem occurred. So we're going to start with the peripheral tissues, and in this particular example, we're looking at the left side of the face. The lymph is then going to be picked up by lymphatic capillaries. It will then flow into afferent lymphatic vessels, where it will enter lymph nodes and then leave the lymph nodes through efferent lymphatic vessels. These vessels will then join together to make larger lymphatic trunks. And because we're talking about the left side of the body, the lymphatic trunks will drain into the thoracic duct, which will then dump the lymph back into the left subclavian vein. But then I also want to remind you of what happens to lymph from the right side of the body, specifically the upper right side of the body above the diaphragm. That will go into the right lymphatic duct and then into the right subclavian vein. So removing lymph nodes can block the normal flow of lymph from peripheral tissues to the venous system. So in our patient's case, we had the removal of lymph nodes in his neck, which is then going to cause fluid to back up, which is what eventually causes the swelling of the left side of his face. So this patient's problem was the removal of the lymph nodes and elimination of a major portion of the lymph drainage pathway. And that is the end of the Chapter 22 activity.